Laparoscopic splenectomy is an effective and safe intervention for hypersplenism secondary to liver cirrhosis by Drs. Peng, Kai, Chen, Wang, and Wu from the Department of Hepatopancreatic Surgery in West China Hospital, Sichuan.
Dear ladies and gentlemen, good afternoon. It's my great honor to have an opportunity to be here, share with my studies. I'm from Department Hepatopancreatic Surgery of West China Hospital, Sichuan University in China. My topic today is laparoscopic splenectomy, an effective and safe intervention for hypersplenism secondary to liver cirrhosis. As a common complication in patients with chronic liver disease, hypersplenism correlates with a severe rate of cirrhosis, leading to drops in platelet count, leukocyte count, and hemoglobin levels. Over the past decades, ARS has become the standard procedure for removal of low to moderate enlarged spleens, especially in presence of hematological disorder, such as ITP, because it has present a great advantage over open splenectomy in terms of less blood losses, short post-hospital stays, and few complications. However, the safety of the ARS for patients with hypersplenism secondary to liver cirrhosis is still debatable. Only few studies have examined the safety and the effects of this approach. Therefore, we conducted this study to investigate the effects and the safety of the ARS for patients with hypersplenism secondary to liver cirrhosis. There are three groups in total in study. In group 1, there are 24 patients with hypersplenism, received ARS, laparoscopic splenectomy. In group 2, 24 patients with hypersplenism received open splenectomy. In group 3, 68 patients with ITP also received ARS. Group 1 and group 2, group 1 and group 3 were compared in terms of demographic, intraoperative and postoperative were respective. Next, share with you my operation of ARS briefly. The surgeon and the scopical assistant stood at the patient's right, and the first assistant stood at the left. General 4 ports were set. A 10 millimeter trocars and a 2 millimeter trocar and a 12 millimeter trocar were used. A 12 millimeter trocar at the left middle clavicle, below the margin of the spleen, for the use of ultrasonic dissector and laparoscopic vascular stopping. This is operation procedure. Takarona observed the spleen size is key factor for successful laparoscopic splenectomy because it is difficult to find adequate working space for manipulations, and the splenomegaly is a common reason for the longer operative times associated with ARS. We also get similar results in our studies. The detailed results of study are summarized and present in Table 1, 2, 3. Table 1 demonstrated the demographic comparison between the Group 1 and the Group 2, and the Group 1 and the Group 3. The Table 2 shows the intraoperative variable comparison, including operation time, acid blood losses, spleen weights, accessory spleen, transfusion, conversion, liver biopsies, and so on. Table 3 compares the variable of of hospital stays and the senior aortic and complication, and it demonstrated that there is statistical significance between the group 1 and the group 2, and no statistic significance between the group 1 and the group 3. Our study was retrospective and long-randomized. Our results suggest there is an effective and safe procedure for hypersplenism secondary to liver cirrhosis. Thank you very much.
This paper is open for discussion from the floor. At the front mic.
Thank you for the study. Hani Haida from Kuwait. How many of these patients developed portal vein thrombosis after doing the splenectomy?
Estimated?
Portal vein
How many
thrombosis.
patients developed portal vein thrombosis?
So you have good questions. Maybe 4 patients have amyloidosis. 4 patients in laparoscopic splenectomy due to liver cirrhosis. Are you okay?
And how many developed it post-operatively? That's
Yes,
the
yes.
question you're asking.
Yeah.
Post-operative complication.
Yes.
So you have a good question. You can give me your email address after meeting. You can discuss this.
These are obviously very challenging splenectomies, and I wondered, I wasn't certain from your presentation whether you used a hand assist approach or whether this was a purely laparoscopic approach.
Use hand?
Do you use the hand assist approach?
No.
So it's a purely laparoscopic approach.
Yeah. Total laparoscopic.
It's a pretty challenging thing, so it's a great compliment to your results that you are able to complete these procedures with such success. But it's a good question. Portal vein thrombosis is a dreaded complication of this disorder, and in cirrhotics is obviously going to be a higher incidence.
Yeah, so I can answer you. The complications, group 1, and the pure effusion, and 1, and pancreatic leakage, and 1. No incision infection, and pulmonary infection, and 1. Group 1, and post-operative bleeding, and 1. Splenic foci abscesses is not. Okay.